Imagine holding a high-speed drill, spinning at thousands of revolutions per minute, and you're operating in an area about the size of a thimble.
Right, it's an incredibly tiny space.
Yeah, so now imagine maneuvering that spinning drill a single millimeter away from the delicate wiring that controls a person's ability to smile, blink, or speak.
Honestly, it sounds terrifying.
It really does. But in the microscopic world of otolaryngology, that isn't some nightmare scenario. That's just, a standard Tuesday.
Yeah, it demands an almost unimaginable level of mechanical control. I mean, we tend to visualize high-stakes surgery as these expansive scenes, an open heart procedure with a wide-open chest cavity.
Right, a massive pumping organ.
Exactly. But working inside the temporal bone, which is the dense structure housing the inner ear, requires an entirely different mindset. The scale is microscopic, but the stakes are life-altering.
Welcome to today's deep dive. We are thrilled you're joining us. Today, we're opening up a rather intense medical textbook excerpt titled Complications in Otolaryngology Head and Neck Surgery.
It's a fascinating text, really.
It is. And just to set the ground rules, our mission for you today isn't to hand you a scalpel and train you to become a surgeon.
No, we strongly advise against attempting any of this, on your own.
Definitely not. Instead, we're taking you on a high-stakes, behind-the-scenes tour of the mastoid bone. We want to explore the unbelievable precision required in what's called a mastoidectomy.
And more importantly, decode the real-time problem-solving that these surgeons have to deploy when the anatomy essentially fights back.
To really grasp the tension of these procedures, you have to look at how the surgeon approaches the room before a single incision is even made. Right?
Oh, absolutely. In a microscopic environment, you cannot adapt to chaos. You have to preemptively eliminate it.
Because the textbook explicitly details the necessity of controlling the entire operating room. We're talking zero disruptive noise, triple checking equipment, stuff like that.
Yeah, and ensuring total synchronization with the anesthesia team, because the physiology of the patient completely dictates the visibility of the surgical field.
Wait, how so? Like their breathing?
Well, their blood pressure. If the patient's blood pressure creeps up even slightly, the tiny vessels in that bony cavity will bleed more.
Oh, wow. And when you're working through a microscope in a space the size of a coin, a single drop of blood doesn't just make a mess up.
It completely blinds you. And that blind spot is what leads to complications.
Right, especially for high-risk cases, like the text mentions severe trauma or something called a cholesteatoma.
Yeah, cholesteatoma. And as we know, that isn't just a simple cyst. It's an abnormal collection of skin cells deep inside the ear that aggressively expands.
It actually erodes the surrounding bone, doesn't it?
It does. It destroys the architecture as it grows. It acts like a slow-moving bulldozer in the ear.
So because it distorts all the normal landmarks, the surgeon can't just rely on textbook anatomy when they go in.
Exactly. They heavily utilize high-resolution computed tomography HRCT scans to map the specific terrain beforehand.
Because it's often degraded, right?
Yeah, they have to plot where the remaining bone is paper thin and where the vital structures are exposed.
This entire pre-op routine reminds me of the meticulous checklist a pilot runs through before a transatlantic flight.
That's a really good analogy, actually.
Yeah, you don't just jump in the cockpit, hit the ignition, and figure out the weather in the air. You build a controlled, predictable bubble on the ground.
Because once that drill starts spinning, you're officially in the air. There's no hitting pause.
Right. And once they are in the air drilling into that bone, they immediately have to navigate around the surgeon's greatest fear in this anatomical sandbox.
The facial nerve.
Yes, the facial nerve. According to the data in the text, unintentional injury to this nerve happens in about 1 in 1,000 cases.
And that's even for highly experienced surgeons.
Which is wild. And while 1 in 1,000 sounds mathematically rare, given the sheer volume of ear surgeries performed globally, it's a persistent, haunting reality.
Oh, absolutely. And the consequences outlined here are just devastating. We're talking about permanent facial disfigurement.
It physically alters how a person interacts with the world, doesn't it?
Yeah, because the facial nerve controls all muscles of expression. If it's severed or severely damaged, the patient might suffer from paralytic atropion.
Paralytic atropion, that's where the muscles supporting the lower eyelid fail, right?
Exactly. The eyelid droops outward, unable to close, which leads to chronic severe eye exposure and potential vision loss.
That sounds awful. And the text also mentions oral incompetence, leading to constant drooling and an inability to speak clearly.
Which naturally cascades into severe psychosocial effects. The text highlights the profound depression, negative self-image, and social rejection that follow.
So looking at the mechanics of the surgery, how does the drill actually compromise that nerve? I imagine the nerve is naturally protected by something.
It is, yeah. It's encased in a bony canal. But the nerve takes a very complex winding path through the ear.
So there are specific danger zones.
Right. The most common site of surgical injury is a specific sharp bend in this path called the second genu. It's where it transitions between two different anatomical segments.
And because it sits right in the crosshairs of the surgical approach, the injury is almost always traced back to how the surgeon handled the overlying bone.
The text mentions two main culprits: faulty drill technique and thermal injury. Faulty technique makes sense. If you slip, you cut the nerve.
Right, but thermal injury is fascinating. We aren't talking about cutting the nerve, we're talking about cooking it.
Yeah, that is the insidious nature of friction. Surgeons are using diamond burrs to grind away dense ivory-like bone, and that generates immense heat.
So if the surgical assistant isn't aggressively irrigating the field, literally flooding it with fluid to cool the drill bit, the heat transfers directly through the bone.
Exactly. The bone acts as a thermal conductor. The heat simply cooks the delicate nerve tissue resting inside its canal,
causing temporary or even permanent paralysis without the drill ever even touching the nerve itself.
Yes, and this brings up what I found to be the most counterintuitive part of the entire excerpt.
Oh, the surgical mantra.
Right. To avoid this catastrophic outcome, the text offers a mantra. Make the facial nerve your friend.
Yeah, I saw that. It instructs surgeons to start at a bony landmark called the Miswen triangle, which acts like nature's X marks the spot for safe entry.
And then they methodically drill down to find the facial nerve on purpose.
See, my instinct says if you're terrified of a wire, you stay as far away from it as mathematically possible. Why poke the bear by actively looking for it?
Well, it's the exact paradox that trips up novice surgeons. They think safety lies in distance.
So they just try to avoid it entirely.
Yeah, they try to drill a tiny narrow tunnel straight to their target, hoping they just bypass the nerve in the dark.
But if you don't know exactly where that nerve is hidden within the bone, every single millimeter you advance is a blind gamble.
Exactly. You're operating in fear. So by finding it intentionally, you strip away the mystery. You turn an invisible looming threat into a highly visible, safe landmark.
Oh, I see. The textbook advocates for wide methodical suspension, right?
Yes, instead of digging a narrow well, the surgeon gradually shaves down a wide, shallow bowl.
They thin the bone over the nerve using a slow, coarse diamond burr until they can actually see the pinkish hue of the nerve shining through a microscopic layer of bone.
And the text even mentions encountering sentinel bleeders, these tiny, specific blood vessels that lay right on top of the nerve sheath.
Acting like natural warning beacons.
Right. Once you see those beacons, you've successfully mapped the hazard. You've made the nerve your friend.
And then you can aggressively drill in the surrounding areas with absolute confidence because you know exactly where the boundary is.
Precisely. But, inevitably, statistics catch up. If an injury does occur, the management protocol seems to be a race against inflammation and structural loss.
From my reading, if the surgeon notices the injury immediately, they flood the patient with high-dose intravenous corticosteroids to fight the swelling.
Right. But if the drill actually severs the nerve, they have to physically rebuild the wiring. The surgeon has to pivot instantly from drilling to micro repair.
So if the nerve is cut but there's no tension, they'll attempt a direct repair, carefully suturing the protective sheath of the nerve ends back together.
However, if the drill destroyed a segment of the nerve, leaving a gap, you cannot just stretch the ends to meet. That creates tension, and stretched nerves die.
So they have to scavenge from elsewhere.
Yeah, they perform what's called a cable graft. They'll harvest a piece of a sensory nerve from the patient's neck or leg, bring it up to the ear, and splice it in to bridge the gap.
Wow. It's a desperate salvage operation to restore at least some baseline facial tone.
It is. Navigating that nerve requires avoiding active mechanical destruction. But as we move deeper into the textbook, the nature of the risks shifts entirely.
Right, because the surgeon isn't just worried about cutting a wire, they have to manage catastrophic fluid dynamics. Because right next door to that nerve is a major drainage pipe.
The sigmoid sinus.
Yeah, sigmoid sinus. It's a massive critical vein that drains blood away from the brain.
And the anatomical trap here is that in some patients, this massive vessel is located just a few millimeters beneath the outer layer of cortical bone.
So a surgeon can be making what they think is a shallow, safe stroke with a cutting burr and can suddenly nick the wall of the vein.
And the text paints a very visceral picture of this. It says the entire surgical field is instantly and completely flooded with blood.
You lose the microscope view, you lose the landmarks, you just have a sea of red.
It's terrifying. Now, if a major vessel connected to the brain tears, my instinct is that you need to clamp it immediately or start suturing.
Right, but in a thimble-sized space, there's no room for instruments. And the medical solution outlined in the textbook honestly blew my mind.
Oh, the gel foam.
Yes, they take a tiny piece of gel foam or a bit of the patient's own muscle, put it over the hole, and just press down on it with a cotton sponge for a minute. That sounds almost too simple for brain-adjacent surgery.
It really does sound like fixing a burst pipe with a piece of chewing gum, doesn't it?
Exactly. How does that even work?
Well, it leverages the specific physics of the circulatory system. The sigmoid sinus is large, but it's part of the venous system, meaning it carries low flow, low pressure output.
Ah, so it's not an artery pumping blood out at high pressure like a fire hose.
Right, it's drainage, not delivery. Because the internal pressure of that vein is so remarkably low, gentle external pressure is enough to overcome the outward flow of blood.
So the surgeon just holds the gel foam in place with a suction tip, and after about 1 minute, the external pressure stops the active bleeding.
Yeah, and they leave the packing there for another 10 minutes, giving the body's natural clotting cascade time to seal the breach. It's a remarkably low-tech, elegant solution.
However, there's a terrifying caveat if the tear is too large.
Yes, if the inside of that vein is widely exposed to the air, the physics flip against the surgeon.
Because the pressure inside the draining vein can actually be negative relative to the atmospheric pressure in the operating room.
Exactly. An open vein can act like a vacuum, sucking air directly into the bloodstream.
An air embolus.
And an air bubble traveling through the venous system directly to the heart or lungs is rapidly fatal. The anesthesiologist has to immediately act.
Placing the patient in Trendelenburg's position. Right.
Yes, which means physically tilting the entire operating table so the patient's head is pointing down toward the floor and their feet are elevated.
Oh, wow. So by using gravity to push blood toward the head, you artificially increase the venous pressure in the brain.
Right, changing the gradient so blood pushes out of the tear rather than air getting sucked in.
From there, the surgeon might have to deploy vascular balloon catheters to plug the vein from the inside out just to regain control.
The speed at which they have to pivot from microscopic drilling to macro-level physics manipulation is just astounding.
It really is. But fluid dynamics aren't just a risk with the blood supply. They are the core function of the inner ear's balance system.
And the text introduces a piece of surgical slang here that's not me cold. Snake eyes.
Yeah, snake eyes is an incredibly ominous term for a medical textbook. What exactly does it mean?
It refers to an iatrogenic labyrinthine fistula. Specifically, it happens when the surgeon inadvertently drills straight through the dense, ivory-colored bone that encases the lateral semicircular canal.
The semicircular canals being the tiny, fluid-filled loops that act as the body's internal gyroscope, right? The ones telling us our position in space.
Exactly. When a surgeon breaches that canal, they look through the microscope and suddenly see two dark, fluid-filled holes staring back at them from the white bone.
Snake eyes.
Yeah. It means the closed hydraulic system of the inner ear has been compromised. And the immediate danger here isn't just the breach itself, it's how the surgeon reacts to it.
Right, because we just talked about using suction to clear away blood from the sigmoid sinus. But if a surgeon sees snake eyes and reflexively reaches for the suction,
It's game over for the patient's hearing and balance.
wait, really? Just from suction?
Yes. The inner ear houses the membranous labyrinth, which is an incredibly fragile structure, suspended in fluid. If you place a suction tip anywhere near an open semicircular canal, the vacuum will literally suck the membranous labyrinth right out of the inner ear.
Oh my goodness. You'd instantly, irreversibly deafen the patient and destroy their sense of balance.
Absolutely. The protocol demands immediate cessation of drilling. You banish the suction from the field entirely.
And then, much like the gel foam fix, we return to the carpentry-style solutions of microscopic surgery.
Right, the surgeon has to immediately plug those two dark holes with bone wax or connective tissue called fascia.
Essentially spackling the closed hydraulic system back together and just hoping the delicate hair cells inside weren't fatally disrupted.
And it isn't just physical breaches that threaten hearing, it's the sheer kinetic energy of the tools. The textbook highlights acoustic trauma.
Because remember, sound is just vibration. If the surgeon is working clumsily and the shaft of that high-speed drill physically bumps into the incus, one of the tiny middle ear bones, the outcome is severe.
Yeah, the incus acts like a tuning fork in that scenario. The drill is spinning at tens of thousands of RPMs.
So if it touches the bone, that violent vibration is transmitted directly through the mechanical linkage of the ear into the cochlea.
It creates acoustic trauma so severe that it specifically obliterates high-frequency hearing, typically 4,000 hertz and above.
The text notes that if you examine the incus afterward, you can physically see an unnaturally flattened aspect on the microscopic bone where the drill bit grazed.
It's a permanent signature of a momentary lapse in spatial awareness.
Yeah.
So we've navigated nerve, we managed the bleeding, we protected the balance system.
But the structural integrity of this cavity extends upward. The roof of the mastoid bone is the floor of the skull. The surgeon has to deal with the ceiling caving in.
We're talking about the durameter. As we know, the dura is the tough fibrous outer envelope that encases the brain and holds in the cerebrospinal fluid, or CSF.
And just like the facial nerve, the text warns that surgeon's fear of the dura might cause them to avoid identifying it, leading to disaster.
Right, because the ceiling isn't perfectly flat.
Not at all. The natural curvature of the middle cranial fossa actually dips downward, bulging inferiorly into the surgical space of the ear cavity.
So if a surgeon is drilling inward with the assumption that the roof is a flat plane, they'll drive the burr right into that downward slope of the brain casing,
Tearing the dura introduces a host of massive neurological risks. The text outlines the possibility of a meningoencephalocele.
which is a terrifying scenario where the actual brain tissue herniates downward through the bony defect and into the ear cavity.
Short of that, you get the cerebrospinal fluid leak. But how does a surgeon, looking at a microscopic field filled with irrigation fluid and blood, realize that the clear liquid pooling in the ear is actually brain fluid?
They rely on the physical properties of the fluids. They look for the halo sign.
The halo sign.
Yeah, if you take a drop of the mixed fluid from the ear and place it on a piece of filter paper, the physics of viscosity take over. Blood is thick and heavy, while CSF is very thin, almost like water.
So the CSF wicks outward through the paper fibers much faster than the blood.
Precisely. The heavy blood cells stay concentrated in the center, and the lighter cerebrospinal fluid races ahead, creating a distinct clear ring, a halo around the red center.
Wow. It's an immediate low-tech diagnostic tool.
Exactly. For absolute confirmation, they send a sample to the lab to test for beta transferrin, which is a protein exclusively found in CSF.
And the fix for a breach in the brain casing, once again, it leans heavily into anatomical carpentry.
If the tear is small, without herniating brain tissue, they use bone pate.
Bone pate, like a paste.
Yeah. The surgeon collects the healthy bone dust generated during drilling, mixes it with a little fluid to create a thick biological paste, and physically spackles the hole in the roof. They layer fascia over it to hold it in place while it heals.
But if the breach is catastrophic, the structural fix requires neurosurgery. They might have to perform a craniotomy, opening the skull from above to lift the brain.
Right. Repair the dura with artificial cement or cartilage, and place a lumbar drain in the patient's spine to actively siphon off CSF.
Reducing the fluid pressure in the head so the ceiling of the ear can finally heal, the escalation of interventions is staggering.
It really is. But as we reach the end of the text, there's a fascinating shift in perspective.
Right. We've been deep in the weeds of life-threatening crises, brain fluid, air embolisms, paralysis. Yet in the very same chapter, the text dedicates significant space to post-operative complications that sound purely cosmetic.
For instance, the displaced pinna, where the patient's ear physically sticks out further from their head after surgery.
How does a surgeon balance surviving the table with these seemingly minor aesthetic outcomes?
It requires an understanding that the surgery doesn't end when the patient wakes up. The true measure of success is the patient's long-term reality.
Let's look at the displaced pinna.
Well, the mechanics of healing dictate that scar tissue contracts as it matures. If the surgeon makes their initial incision too close to the crease behind the ear, failing to leave a necessary 1 centimeter margin of tissue, that inevitable scar contracture acts like a physical tether.
Oh, I see. As it shrinks, it pulls the cartilage of the ear outward.
Exactly. So while it's completely non-life-threatening, for a patient, especially one with short hair, it's a permanent, highly visible broadcast of surgical failure. They have to see it in the mirror every single day.
Yeah, and a purely structural failure leads to an even more chronic issue, the unstable cavity. cavity.
The text warns heavily against creating a sump effect.
Right, from an engineering perspective, a sump is basically just a low spot, a gravity trap where fluid and garbage collect.
Is that what happens inside the ear?
That is the exact anatomical hazard. If a novice surgeon ignored the advice about White's authorization and instead dug a deep, narrow well to reach the disease, they leave behind a hole shaped like a bucket.
So the ear's natural self-cleaning mechanism is destroyed. Debris, moisture, dead skin, and wax simply fall into the bottom of this deep well and sit there. It becomes a permanent incubator for chronic infection.
The text notes that patients with an unstable cavity have to visit the clinic constantly. They need the ear mechanically vacuumed out or packed with boric acid powder.
Or treated with silver nitrate to chemically burn away diseased granulation tissue. An unstable cavity slowly ruins a patient's quality of life.
They live with chronic pain, foul-smelling drainage, and the inability to ever get water in their ear. To prevent this gravity trap, the surgeon must execute proper saucerization.
Which brings us to the most illuminating analogy in the entire excerpt.
Yeah, the text says that properly shaping the cavity to avoid the sump effect is like placing a wet piece of canvas over a hole dug into the ground.
It perfectly illustrates the geometry required. If you dig a steep, narrow hole and throw a wet canvas over it, the canvas drops straight down, creating a deep pocket.
But if you bevel the edges of the hole outward, making it incredibly wide and gently sloped like a saucer, that wet canvas behaves differently.
It drapes immediately. It collapses inward smoothly along the shallow slopes.
By widely skeletonizing the ceiling and aggressively amputating the bony tip at the bottom of the mastoid, the surgeon removes the rigid walls.
The surrounding soft tissues of the patient's scalp and neck naturally collapse inward during healing, filling the dead space safely.
So the surgeon essentially reduces the final volume of the hole without actually having to drill any shallower.
The canvas drapes flat, no sump effect, no trapped debris, no chronic infections.
It's brilliant architectural manipulation designed to trick the body's natural healing process into solving the structural problem for you.
It demonstrates the true mastery in this microscopic field isn't just about avoiding disaster during the 2 hours of surgery.
Right, it's about understanding the mechanical, fluid, and structural forces that will act on that thimble-sized space for the rest of the patient's life.
Unpacking this text really pulls back the curtain on an entirely hidden world.
We tend to take our anatomy for granted, But realizing that all of these critical systems, our facial expression wiring, our gyroscopic balance fluid, our brain casing, our major drainage veins, are all crammed together into a piece of bone the size of a walnut.
It commands an intense level of respect. It shows that a single millimeter difference in the angle of the diamond burr dictates a patient's entire future.
And it highlights the extraordinary, pressure-tested resilience of the medical professionals who train their hands to operate within those millimeter tolerances.
It truly does.
But I want to leave you with a final thought today, something to turn over in your mind as you go about the rest of your week.
Oh, definitely.
We've established that human hands, relying on spatial awareness and tiny spinning diamond burrs, can navigate this terrifyingly cramped space with remarkable success.
Right.
But as we look toward the horizon, how will the inevitable rise of robotic microsurgery or AI-assisted surgical navigation fundamentally change what we even define as a complication?
If a robotic arm can map the bone density and drill to a mathematical tolerance of a single micrometer, will concepts like snake eyes or cooking the facial nerve become historical relics?
And more interestingly, what entirely new, unforeseen structural challenges will replace them when we start operating beyond the limits of human sight?
It is a profound question about the evolution of healing. As our mechanical tools perfect the execution, the burden of failure simply shifts to a new frontier.
A frontier measured in micrometers instead of millimeters. Thank you so much for joining us on this deep dive into the microscopic high wire of mastoid surgery. Keep asking questions, keep exploring the hidden mechanics of the world around you, and we will catch you next time.